It's not just radio, it's Rockland World Radio. RocklandWorldRadio.com.
Welcome to Dialogues with Dan, heard on Rockland World Radio every Tuesday evening at 6:30 p.m. Eastern Standard Time. Be sure to check out the archives, which are located off the menu bar on Tuesday evening. Now the hosts of Dialogues with Dan, Mr. Dan Windheim.
Hi everyone, this is Dan, and the way I like to say, we've got a live one. We have a live guest. I'm speaking with Dr. Dominic Ferro, a psychiatrist here in Rockland County. I'd like to introduce Dr. Ferro. Hi, Dr. Ferro.
Hi, Dan.
Glad you could join me.
It's a pleasure.
Yes. Maybe, Dr. Ferro, we could start by you telling us the types of psychiatry you deal with and the clients you might see.
Okay. I'm a general psychiatrist. I'm board certified in general psychiatry. I also have some added experience with adolescents, and a fair amount of my practice is with adolescents. And I'm also certified in forensic psychiatry, where I do consultations to the courts to help them with questions that they have that might have to do with psychiatric matters.
Wow, that sounds very interesting. Is that like on TV, like you see the forensics, and is it?
It's a little like that. I mean, the forensic psychiatry that they have on the television is often somebody who's working directly with the police, and some people do that. But most forensic psychiatrists are, they'll do an interview with somebody. Sometimes they'll go to a jail to interview somebody who's incarcerated at the time. But then they spend a lot of time in their office writing reports by themselves, and it's not quite as exciting as what happens on television.
Right. Maybe you could give a fictional example of the type of person you might work with, whether it be a child, adolescent, an older person, or like you had said, in the courts type people.
Okay.
Yes.
Well, I'll talk about a typical adolescent type of case, since you had approached me about talking about adolescent psychiatry today. The most common disorder that people might bring their child to a psychiatrist for is attention deficit hyperactivity disorder. It occurs at a very high rate. Maybe there are some studies that say maybe as many as 5% of students would meet criteria for that disorder. So that would be a pretty common presentation. Somebody would bring their child and they would be having some problems keeping up with school. I'm an adolescent psychiatrist. I don't see young children. So the kid who can't sit still and is bouncing out of his chair, and the first grade teacher says, your son was looking out the window the whole time watching a butterfly fly around. Maybe you should have him see a psychiatrist. They wouldn't bring them to me. They would go to a child psychiatrist. So I don't usually make that kind of diagnosis. I would the more common patient for me would be somebody who was pretty well behaved and didn't have a lot of impulsivity, but had trouble focusing in school. And they did fine when they were in elementary school, but then as they got older and the work started to become more demanding and they had to do longer projects, their problems with attention started to become more of a problem. And so I would help the parents identify that, and we could start some treatment for that.
Yes, and obviously, as a psychiatrist, writing prescriptions is a big part of your life. But a lot of people are against medications and don't like that. And so there are other areas of dealing with dealing with problems, such as?
Such as psychotherapy, which I do a fair amount of in my practice. I enjoy doing psychotherapy. When I first was going to do my psychiatry residency, I thought that I was going to do lots and lots of psychotherapy. I thought I would be I was thinking about going to a psychoanalytic institute and helping people by talking to them and helping them understand their problems. And I do that, and I do enjoy doing it. But like you're saying, a lot of psychiatric practice does have to do with medications, because often if somebody just wants counseling, they might go to a clinical social worker or a psychologist and get their counseling there. The people who are coming to me are sometimes people who have been sent by their psychologist or social worker. Sometimes people come directly to me, but often it's a problem already that's been identified as something that they are considering medication for. So most of the people that I see are pretty open to the idea already.
Yes. Yeah, I know. As far as medication, I know years ago, and maybe still, only a psychiatrist could prescribe. But I thought that I heard, like in recent 10 years, that they've changed the rules, that even different doctors could prescribe. Is that right?
Any doctor can prescribe any medication. It's more a question of do you have the training and the experience to safely prescribe that medication? So, I mean, I could write prescriptions for someone with cancer to get chemotherapy, but that would be a bad idea because I'm not really keeping up on that, so that's not an area. But I could technically write that prescription. Primary care doctors do probably write most of the prescriptions for psychiatric medications, just because everybody has a primary care doctor, but not everybody has a psychiatrist. So a lot of people, their problem might be identified by their primary care doctor, and they might get treatment. And maybe that treatment goes fine. They take some medication, it helps them, and then they just continue to see their primary care doctor until they either resolve it or they'll stay on the medication with him or her. And the people that come to psychiatrists are often cases that are a little bit more complicated. Although some people go directly to a psychiatrist, they don't want their primary care doctor to be writing their prescriptions.
Really? You said that an MD could write a script for psychiatric meds?
Sure.
Really?
Sure. Any doctor, once you get your medical license, you're good to go. You can write any prescription that you want, any medication that's in the armamentarium. Yeah. But it's more a question. I mean, it's the doctor's job to be responsible. When somebody comes to me, I have a duty to do what's right by them and to practice within my expertise. So I would not try to treat people with other medications for conditions that I'm not really keeping up with. And
I never knew that. That MDs, I mean, not MDs, but say a doctor
now, I went to medical school with those doctors, so I do consider myself a doctor. But yes, the family doctor, right.
Could write psychiatric medication.
Your gastroenterologist can write psychiatric. Your surgeon can write psychiatric medications.
Don't always recommend it.
No, not always. Some primary care doctors, they take the time and they're interested in treating psychiatric problems, and they do a good job with it.
Interesting. And so, I imagine you see boys, girls, teens, young, old, poor, rich, and what is the setting which you see patients?
I have a private office in Nanuet. I see most people are paying me just a fee for service, where because I'm not participating in most insurances. I do take Medicare though, and I also take workers' compensation insurance coverage. So that's how I get some mix of incomes in my practice. But that's where most of my work is. I also work part-time at the Rockland County Jail, or the Rockland County Correctional Facility, as it's officially called, and I see people who are incarcerated there one morning a week.
Is that part of your dues that you? Is it pro bono?
No, it's not pro bono. Actually, I used to. I've worked in public psychiatry during my career. I worked at for a state hospital in Orange County, the Mid-Hudson Forensic Psychiatric Center, which is a facility for people who have committed crimes and they're awaiting to have their crimes adjudicated, or they've been found not responsible for their crimes.
Yes.
And then I've worked for the Rockland County Department of Mental Health for several years as well. And so my work at the Rockland County Correctional Facility is part of my work for the Department of Mental Health. It's a very, very part-time thing, but it's nice to get out of my office and work with other people.
Very good.
Mm-hmm.
Do you have a preference? As all your work, do you have a preference of the type you do?
Mm-hmm. I like all of the work that I do. It's nice to have a mix of things. It is nice to go and be in a different setting one day a week, or to do some evaluations for the courts, and sometimes to testify in court. And I enjoy working with people in my office as well.
Yeah, that's great. So you get a nice mix of one-on-one work and work with an office.
Right.
Do you do any groups?
I do not do any groups. It's a little bit difficult to get a group together.
Yes.
You know, everybody has different schedules. So I have tried a few times, and I've had some groups going for periods of time, but mostly it's individual work. You know, when I work with adolescents, obviously I'm meeting with family members, parents, sometimes siblings too, and so sometimes I get a few people in my office at a time that way.
Mm-hmm. Did you ever work for a school district?
I have not worked for a school district, but I have been consulted by school districts to address questions. Sometimes schools have questions about if a student is having problems and they think that there might be a psychiatric aspect to the difficulty that they're having. Sometimes I've been asked to help them understand what's going on with the child.
Yes. So you say that you do adolescent psychiatry. How does that differ than other types?
Well, it's a good question. Most of psychiatry is, we talk about imbalances, chemical imbalances, and things like that, and we do understand a lot more about the way that the brain works, but unfortunately, we don't really have a great understanding about exactly what's happening in people's brains when they have different problems. I can't do any kind of scan at this time. We just don't know what to measure. The brain is very complicated. There's a lot of neurons communicating with each other all at the same time, and we just can't really, we don't have the wherewithal to measure that yet.
Sure.
So when somebody comes to see me, a psychiatric diagnosis is still relying on talking to the person. They tell you how they feel now. They tell you the things that have happened. You observe their behavior and their mood and the things that they say. So, and that's basically how we make our diagnoses. So the thing that's different with adolescents than adults is that adolescents are still developing their ability to see themselves. They're kind of new to that. And when a person's an adult, they have more experience with themselves, and so they can give you a more full description. But adolescents, a lot of times their behavior is still kind of speaking for them before their words have caught up necessarily with it.
Yes.
So it's important to communicate with parents and family members, sometimes schools as well. So I do talk to teachers and guidance counselors about what behaviors have been happening at school to try to understand what the issues are.
Sure. I would imagine that working with adolescents, correct me, that, like you had said, the adolescent brain is definitely not complete. It's changing like daily, and I mean that must be like so difficult because it's not black and white, it's not cut and dry, and like you said, everything's going from one child to the next. They might have similar diagnosis, but it's completely different.
Well, that's a good point. That actually is another difference that happens in adolescent psychiatry than in working with adults. Adults have their history already. Adolescents are just at the beginning of their history, both in their life, but also if they have any kind of psychiatric problem, that psychiatric problem is also at the beginning of its life. So, for instance, if somebody has bipolar disorder, if I see a 35-year-old man with bipolar disorder, he'll come to me and he'll tell me, well, when I was 16, I was depressed. And then when I was 21, I had this manic episode and I thought that I was Jesus or whatever it would be, and they would, and that would happen for a period of time, and then they might be okay, and then they might have had another depression later on, and then another manic episode. So when they come to me at 35 years old and they say, I have bipolar disorder, I can see that they have bipolar disorder from going over their history with them. But if that same person, if I meet them when they're 15 and they're depressed, I don't know that they're going to have bipolar disorder. I just know that they're depressed now. And it's hard to even tell, is this normal adolescent moodiness, or is this something that is depression? So that's kind of the challenge of adolescent psychiatry. But it's also the thing that's exciting about adolescence is that you don't quite know how the story is going to unfold, and you're trying to figure out and help them take the next right step in their lives. So
yeah, I could see it's very exciting. I mean, you always hear, oh, it's just a phase. They'll grow out of it. But it might not be.
But it might
or
not.
might be a phase that's going to metamorphose into another phase.
Right.
And their adolescent with difficulty become an adult with difficulties.
Yes.
So it's never this or that.
It's not clear yet.
Yes.
The story isn't told.
Yes. Which you must find exciting, but also frustrating.
I think that to be an adolescent psychiatrist, you have to kind of remember your adolescence and like adolescence, and I don't mind working with adolescents. I think it balances out. It is exciting. And also, an adolescent, even if they are developing a psychiatric problem, that's going to be something they're going to have to contend with into their adulthood.
Yeah.
Handling that well now puts them in a position where later they might be handling that well. And they might be a person, even though they might have depression or anxiety or even something more severe like bipolar disorder or schizophrenia, but handling it well now puts them in a position to handle it well into their adulthood. And really you can feel good about changing the course of someone's life when that goes well, because sometimes you could start to have problems in your adolescence and then you could do things to make it worse. Like, it's not uncommon. A lot of adolescents experiment with drugs and alcohol. An adolescent who's developing a problem with depression or bipolar disorder who starts to deal with that by experimenting with drugs or alcohol might make their condition much worse and have a much more difficult time. So being able to make that intervention at that time, although it is frustrating and there's more uncertainty, it also can be rewarding, and you can feel good about helping somebody change the course of their life.
Yes. Maybe at this time you could share, do you know your email? You could offer your email, phone number, and maybe your name, and how people could contact you.
Okay, well, thanks. That's nice. The office phone number is 845-623-0658, and my email address is drferro, like Dr. Ferro with no period, at optonline.net.
Yes. And your address?
It's on Prospect Street in Nanuet, 152 Prospect Street.
Very good, thanks. Yeah, we had spoken about medications. Maybe would you give like a short list of the different meds that might be used, to deal with problems?
Sure. There's a lot of medications that are available. Psychiatric problems are not uncommon. If you think about it, our brain is the organ in our body that has the hardest job. It has to make us who we are. Yes. A heart just has to pump blood, a kidney just filters it, but your brain has to create an identity. So it has the hardest job, and it's also easier for things to go awry with it. So there are a lot of different problems, and it's not uncommon, those problems. A very large percentage of the population at some point will have some psychiatric problem. So there are different medications, and yes, pharmaceutical industries have tried to get in because it's a big market, because they do happen commonly. But the classes of medications that we have, when we talked before about attention deficit hyperactivity disorder, there's a lot in the press about stimulants and like Adderall and Ritalin, and people are concerned about inappropriate diagnoses. And, maybe if you go to your pediatrician and you say he's not concentrating in school, and if the pediatrician just writes a prescription, maybe that's not such a good diagnosis. Maybe you want to try to figure out what the problem is. But if you do figure out that that's a problem, if you go to a psychiatrist and they do a full evaluation, and those medications are very effective. They're some of the most effective medications in all of medicine, actually, and I've seen a number of times where people's lives are just changed. A kid who's doing his best in school and is not doing so well now is doing his best and is performing up to his ability or her ability, and enjoys that more, takes more pride in their work, and and things just change for them. There are also antidepressants are fairly effective medications, yes, for many adults, and there's a number of different, I could rattle off 10 different antidepressant medications.
Yes. Do you deal excuse me, do you deal with maybe like suicide ideation?
Mm-hmm.
And that's very in the news the last 10 years. It's
mm-hmm.
been off the charts. How have you found that? Do you think doctors, or as a society,
mm-hmm.
do you think we have a better grasp of that now?
Well, thankfully, suicide is still an infrequent occurrence. So even though, when we say, suicide rates are up, you're still talking about, every one in several thousand people might commit suicide. So if it goes up to 1.2 people, that's a lot of people, and it's a significant increase, but it's still a pretty rare thing. And it's not so easy to find the people who are going to commit suicide and study them. It's not. We've learned a lot about suicide and suicide prevention, and a lot of the people who commit suicide are depressed at the time that they do, and so, which is part of the reason that it is important to get treatment if you're feeling depressed, and to because that does lower the rate of suicide.
Yes.
Treatment does help to decrease that, but it is, like I say, a rare event, and there are other factors that go in. I mean, many millions of people are depressed. A very small percentage of them will commit suicide. So there are other factors, crises that are happening at the time. Substances, yes. Alcohol is very commonly involved in completed suicides.
Yes.
And it's often just a moment of despair, and a person
yes.
makes, and there's an element of impulse about it too.
Sure.
Even if a person plans it out a little bit, but they're just in a bad state of mind and they're following that through. So. You try to look for the risk factors and the telltale signs that people are thinking about that and intervene.
Aren't suicide ideation?
Mm-hmm.
It's hereditary, isn't it? Or
is
that not?
Well, there's definitely a component of that. That is a risk factor. If you have somebody in your family who committed suicide, you're more likely to commit suicide than a person who didn't. Still not likely, but more likely. So there is definitely some genetic component to it, although most people that commit suicide don't have a relative that committed suicide.
Right.
So it's also, like almost everything with genes, they contribute, but they don't tell the whole story.
Sure. But you think, or you recommend that families or friends take it serious, all things serious?
Yes, I think that, a person who's talking about committing suicide, even if they are not intending to commit suicide at the time, they're telling you something.
Yes.
They're having a bad day, or they are depressed if they're
Yes.
thinking about it a lot. And I can tell you in my practice, I've seen people with depression where the suicidal thought is not so much a strategy as it is a symptom. It's just a sign that their depression is back. They're just seeing life differently. They might not even have, like I said before, any intention of ending their lives, but they just find themselves thinking about death, what it would be like to be dead, or they find themselves thinking about death as a relief, which is, usually when we think about something happening that would cause our death, we're frightened, but when a person's depressed, they might see it that way. So,
sure, thanks. Last minute, I want to ask, do you think it's tougher to be a kid today than, say, when we were kids?
I don't think there's an easy answer to that. I think that there are certainly more challenges now. I think that with the turnover in technology being so rapid, it's 200 years ago, a teenager was never better than their parents at anything. They had to continue to learn. But now things change so fast. Parents are kind of obsolete. Children are more familiar with some things that are new that their parents had never encountered. So it's in that way, I think it's more challenging. But I think also it's a wonderful time to be a child. There's lots of opportunities, lots of enriching activities. The children and the 20-year-olds now are going to be the best educated, most tolerant generation in the history of America.
Yeah.
So it's not an all glum story by any means.
Sure. Yes, and finally, in a psychological sense, do you think the world's in a better place than it was, say, 10 years ago? Psychologically speaking.
Well, that's a big question, and it's a big world. I don't know if I could say. I don't think there would be like one answer for the whole world.
Yeah.
Certainly some people are.
It's a smart answer.
Yeah, but some people are still having a hard time in some parts of the world, yeah.
So you think we're doing the best we can, such as we'll continue?
I think so. I think that there's a much more of the world is middle class now than they had been, and it's been shown that being middle class is good for people. Their health is better, they live longer, and their mental health is better. So I think that there's reason to be positive about the way things are going.
Perfect.
Okay.
Well, Dr. Ferro, thanks for joining me.
It's been a pleasure, Dan. It flew by.
With Dan.
Okay.
It did. Well, everyone, Dr. Dominic Ferro on Dialogues with Dan. Peace.
It's not just radio, it's Rockland World Radio. RocklandWorldRadio.com